Starting now. Oh, righty. So, hi, everybody. Welcome to a little short review, just getting your brain ready for tomorrow. Always remember to be prepared for your tests by making sure that you got everything you need and you're in a secure place, away from distractions and everything, and sitting up in a good chair, and also be prepared. So I opened the test for downloading at 2 p.m. Eastern Standard Time. So at 2 p.m. tomorrow, you can download your exam. Okay. So just be prepared. All right. All right. So the first set of concepts, as I said, will fall onto chapter 10. And chapter 10 was your nursing care of women and complications after birth. Okay. All right. So when I say uterine atony, A-T-O-N-Y, what are you all thinking? What do you think when I say uterus without tone? That's a uterus that's soft and boggy, correct? Yeah. Now, can that lead to a postpartum hemorrhage? Yes, it can lead to a postpartum hemorrhage. So let me share my screen from the time that we did this. And here it is. And so let's go to uterine atony. That's our first concept that we're discussing today. So what is it? It's a collection of blood within the uterus. All right. And what happens is a uterus without tone is the muscle fibers, they're very flaccid and they do not compress the vessels of the placenta site. Okay. Remember, the placenta comes off the endometrium. So when that comes off, you've got an area that's open. Is it like a free bleeder? So if the uterus does not clamp down, then what happens? She's going to bleed. Okay. So again, this is a uterus without tone. You need to know this. So she can hemorrhage. If you don't jump on this right away, your patient can die. She'll hemorrhage to death. Okay. So what are your causes? Well, you have a uterus that could be overdistended. I'm thinking multiples, like twins, triplets. Boy, those uteruses are really stretched. And for that uterus to come back down to its normal pre-pregnancy state takes a lot. Retained placenta fragments. You know that placenta still has left a piece up there, and that will cause the uterus to be without tone. Prolonged labor. Person who's in the transitions, maybe if she's having a real long labor, she can also, after she gets done, she can have a uterus without tone. How about Pitocin? The use of Pitocin. If you do an induction of labor in someone and you have a long labor, and finally maybe she started to dilate on you, but you've been doing Pitocin for a while, that uterus is going to be more flaccid after baby comes out because it's been used to all that oxytocin, the Pitocin. How about use of drugs during labor that relaxes the uterus? What medication do you think? That would be, maybe she's a preeclamptic patient. So maybe you use magnesium. Okay. So you have that. Maybe,
oh, I'm sorry. I think something happened to my internet. I think it was
okay, welcome back. I was getting lonely. And anyway, so these are drugs that can be used during the labor that maybe you like for preeclampsia. I'm thinking magnesium sulfate that really relaxes the uterus. All right, so what are the drugs that you would use to contract the uterus if the uterus is experiencing uterine atony? What drugs? Well, the first one is oxytocin or synthetic Pitocin, PIT. P-I-T-O-C-I-N, big one. Oh, excuse me. And then the next one, and you might see this one, Methogen. Methogen is given IM, it's like 0.2 milligrams IM, and it's very strong. It does increase the heart rate, so you better make sure that you take the heart rate before you give it. But usually if someone is hemorrhaging, they're going probably into hypovolemic shock. And usually their heart rate will be very fast, but their blood pressure will be low. Okay, so you'd be okay to give that Methogen. Okay. And you can also give more PIT. So those are the main two. Now, the other two drugs you might see is Cytotec and Hemabate. So know those drugs. Okay, let's go on to, well, here are your characteristics of uterine attenuate. Remember, it's boggy and soft. The fundal height is usually above the umbilicus. And lochia is increased. Yeah, she's bleeding. And she can have large amount of clots. Okay, now I'm going to go back to shock. Let's go back up here to shock. All right. Here. Hypovolemic shock. It occurs, and this is your next concept, by the way. So write down these lists. Hypovolemic shock occurs when the volume of blood is depleted. So through your body, you have circulating blood. And in the blood, blood cells, you have oxygen. And then when these things are depleted and your system can no longer, your organs need blood. So what happens is that the circulatory system can't keep up with the demand, put it that way. So, and if you don't correct hypovolemic shock, your patient is going to die. Okay. So initially what do you want to do? You want to make sure that you make sure that you correct it. Okay. You don't want patient going into shock on you. Okay. So what am I going to do? I'm going to stop the blood loss. I'm going to massage in the fundus. Maybe give IV fluids. Okay. Well, not maybe, giving IV fluids. Now, maybe get blood transfusion to replace the lost erythrocytes. And a lot of times in labor and delivery, what we'll do is we'll red band our patients, do a type and cross for 4 units of packed red blood cells. And then when we need the blood, we're able to get it quickly. Give oxygen, of course. And because whatever red blood cells you got in there, you want to, you just give them more oxygen to get a good saturation rate. And then I'm going to put a Foley catheter in only so that I can keep track of her INO. So if I was to ask you, what should the nurse's first action be when postpartum hemorrhage from uterine atony is suspected? Massage the fundus. So she's going to begin by massaging the fundus. And while you're doing that, you're going to ask for help. Get help. Okay. All righty. All right. The next one I want to talk about is DVTs, deep vein thrombosis. Okay. We talked about that before, DVTs. And basically, what sign would it be that we talked about that if she complained of heat and swelling of her calf, what's that sign called? That's called the Homan sign, Homan apostrophe S, Homan sign. And that definitely, if your patient's on postpartum and she brings a call and she says, nurse, I need help. My leg is hurting. You run down to that room, you assess her, and you find a swollen, reddish looking calf. And when you touch it, she flinches. She goes, that hurts. That's a positive Homan sign. And that can be very much indicative of a deep vein thrombosis. Okay, now DVT can dislodge itself and go right up that saphenous vein right into the heart. and she could end up having a pulmonary embolism. She could die very quickly. It happens. So I'm going to call the doctor, and I'm going to get a Doppler. I'm going to get a venous Doppler study. Okay, moving right along, postpartum sepsis. Important concept to have a good understanding. Remember, she can get an infection very easily postpartumly because she's been through labor and delivery. And that's why we try not to do a lot of sterile vag exams, is because putting your fingers all the time can cause her to have bacteria in the inside the uterus, and that's called endometritis. Know that term, endometritis. And so, we don't want to cause her to have any kind of infection, or she could have another infection called chorioamnionitis. Those are really bad infections. If you're not familiar with those, I want you to look them up. Another bad infection they can get postpartum is a UTI, which can get very complicated, cystitis, and go up a little bit into the kidneys, and you got polynephritis. Well, you don't want her to have a UTI. It's very uncomfortable. So again, we limit the amount of times that we catheterize, and we always try to get them to void on the bedpan during labor. Mastitis, another infection that can happen postpartumly. And don't forget, when I talk about postpartum, I'm talking about from the time in the recovery after delivery all the way through 6 weeks. That's my recovery time. So these are complications like endometritis. She could be at home and start having like a foul odor to her discharge. That's not normal. She could be having pain in her tummy, in her uterus, and that's not normal. Mastitis. She could have an infection in her breasts and be at home and be very, very uncomfortable. And so you want to teach, always want to teach what signs to look for. Mastitis would be what? A red, swollen breast. They get real hard. They don't want to nurse because it hurts. So how would I prevent my patient from getting mastitis? Ashley, you know that one? I'm putting you on the spot, I know. So I would keep my patient. This is what I do postpartum. I watch how the baby nurses. So when the baby latches on correctly, which means he gets the whole areola in his mouth, okay? That's latching on correctly. Then he'll stimulate her mom's pituitary and to let the release of oxytocin, which lets the milk down. Okay, so I always want to teach my patients never to let the baby just stay on the nipple. That's going to cause a cracked nipple, and that could be an entryway into the breast for bacteria, okay? And that causes mastitis. So, I want to keep the milk flowing, right? So, she could take a nice warm shower before she breastfeeds in order to produce. You want to produce the letdown, okay? There's 2 hormones that are associated with breastfeeding. They are prolactin and mastitis. And oxytocin. So 2 hormones. I'm thinking ahead. So 2 hormones, prolactin and oxytocin. Those are 2 hormones that you need for breastfeeding. All right. Wound infection is another way she can get a complication after birth. And it could be from a C-section. And it could be also from a episiotomy. Okay. And so depending upon the degree of the episiotomy, you ranges from 1 to 4. So 1 is just superficial, and each degree gets a little bit deeper, deeper, deeper until the 4th degree is all the way to what? Anal sphincter. Okay. That's really bad. So if my patient has an episiotomy, I definitely want to do my assessment, and that's called REEDA, REEDA. The D stands for drainage. I'm going to look at her lochia. Okay. Edema. Edema. And also back to drainage, I'm thinking too, if I see any kind of purulent drainage coming out of episiotomy, never good. Okay. So I want to see that it's just basically normal loci of rubra. Okay. Then I'm looking for, first E, I said it was edema, swelling. And then the second one is ecchymosis, which is bruising. And then what I got R. Oh, I'm kind of, wait a minute, Ashley, you gotta correct me. Reda, REEDA. Let me repeat this. I think I said it so many times. Red, R is for redness. E is for edema. The other E is for ecchymosis. Now the D. Oh, goodness. D is for drainage. And then the A is for approximation. That's your assessment of your episiotomy. Okay. All righty. In your book, you have a really good chart on bubble heat. Bubblehe. Really good. Go over that. Okay. Know what you're looking at. You're looking at the entire body, are you not? Okay, the breast, the uterus, right? Okay. So go over that so you have that. All right. Those are all we call complications after birth. All right. Any questions, Ashley? Any questions on that? All right. So the next set of concepts that I'm going to go over is going to be on postpartum depression. Okay, so you're going to know postpartum depression and when it occurs. Usually shows its face. Remember my slide on that? Let me see if I can find that one. Let's see. Let's see. Where was that one? On this one? Let's see. Hold on just a minute and let me see. Here. And okay. Here we go. I know I had it. So here is your postpartum depression. So it's just a lack of enjoyment in life, lack of interest in others, intense feeling of inadequacy, unworthiness. How about guilt? Yeah. And they're unable to cope, and they have a loss of mental concentration, inability to make decisions. They can't sleep, they can't eat, and they have constant fatigue. Okay. All right. So what I want to point out to you, I just want you to take note to everybody, it usually manifests within 4 weeks after delivery. These kind of questions you be careful with. You read them carefully, and you always ask yourself, what's this question asking me? Because it will be worded a little bit differently. So you want to look, again, depression shows its face within 4 weeks after delivery. Now, baby blues, on the other hand, right? Remember baby blues? It's very common after birth. So mom has periods when she feels let down. I'm tired. She's tired. And she finds pleasure in her new role as a mom, but she's just overwhelmed. That's the difference. So baby blues is more common. And then as the weeks go by and she doesn't get help, that's how it escalates and she gets into more depression. Because remember, any mood disorder is an emotion, right? That's her perception of her reality. But she's entitled to. So it does color. But if you give her support and she doesn't feel so overwhelmed, then the baby blues, which is very common, will go away. She'll come out of it and she won't be so tired, and she'll eat and she'll sleep. And when you eat and sleep, guys, you feel better. Okay. So I know this cartoon, which I just love, and think about it. And when you have these kind of questions, geez, life, there's a lot of things I got to do. Well, you got to do it. But I did these things yesterday. When will they be done? That's how a mom feels. If you ever been a mom, you know it. So again, going over the difference, depression starts within 4 weeks after delivery. Okay, think you got it. All right. Postpartum psychosis is another one on my list here. This is a little more deeper and is characterized by what? Episodes of mania. All right. This is deep feelings of worthlessness, guilt, sleep, and appetite. So now we got worse. But let me tell you, they do have hallucinations and they have delusions. So that's the difference. We're getting really deep now. Okay. And what you have to worry about with the psychosis is that mom hears these voices. They're not nice voices. Okay. And this voice will tell mom, you're not worthy of having this baby. You kill the baby and then you kill yourself. When we worry about infanticide, we call it infanticide, or we call it, and for mom, it would be suicide. Again, they hear these voices. They just can't help. Okay. Now, let's come out of here and we're going to go into newborn. Okay, so we have the term newborn, which means from anywhere from 37 weeks, okay, to what? 40 weeks is term, right? And I had that slide to show you the different ages. Okay. So go make sure that you go over now. The reflexes. Let's start with reflexes. Okay. So there are such reflexes. They are classified as reflexes that keep an infant alive. Now I'm going to give you a warning. Hesse likes reflexes, okay? So you want to know these. So a gagging reflex, is it not? Does it not keep them alive? Sure. If you couldn't have the ability to gag, what would happen to you? You would just kind of aspirate on everything you were taking in. So you gagging. Sucking reflex, they have to eat. Sneezing, they have fluid in their nose. Remember, they fill up with all the fluid in utero, and when they're born, now they have to let it go, so they sneeze. And blinking, they're protecting their eyes by blinking. Now they can also cry and swallow and lift their head slightly. So these are my term newborns. They also, guys, when you talk about reflexes, think about it. We're talking about the nervous system. When you don't have a reflex, that means the nervous system is not working correctly. That means the brain is not working correctly. So kind of remember that way. Then you have that moral reflex, that startle, you know? And a lot of times it happens in the hospital where you take the little crib and sometimes we come around a curb and we kind of hit the wall. The poor little thing goes, you know, what you doing, nurse? And then we have the rooting reflex. Anything that touches the cheek. I think that was on one of your quizzes. That touches the cheek in anticipation of food. Okay. And then, of course, you have the tonic neck and the dancing reflex. All righty. We're going to go down here. Pain. I want you to understand that newborns do have pain. Okay. So, look over those pain scales in your book. And you know that they're all full. Here they are. That they all have their little way of these ways. What we look for, like cries is a 10-point scale. FLACC, that includes the face, the legs, the activity of the baby, cry, and consolability. PEP, PIPP, and then the NIPS, and the MPASS. You're not going to have to know each one, but know which one is normal and like which one is not. So say like you had a question. Let me see if I have it here. Here. So if I asked you something, which acronym is often used to assess a newborn's pain? Which one would you say? That would be FLACC. Okay, because we know what these are, and so you have why by knowing AROM, artificial rupture membranes, and SROM, spontaneous rupture membranes, you know that that's not there. These have nothing to do with pain. Now, the APGAR score has nothing to do with pain. That score is given to a baby to know at 1 minute and 5 minutes of birth in order to know what level of resuscitation it should be. Okay, so again, you have to just be able to recognize this in order to know which one to pick out. Okay, we got it? All right, now, and I gave you these PowerPoints. If you want to go back over them, it tells you what the prize is and everything else. Okay, let's go on. My other concept I want to go over, oh, is cold stress. Okay, let's go into respiratory, big time respiratory. Okay, all right. Now, these babies, when they come out, their biggest job is to breathe. Believe me, biggest job for them once you cut the cord. Because don't forget, in utero, everything was done for them. They were like little angels in there, just swimming around, having a good time. But not now, they're being evicted, and now they're having to breathe on their own. So the most critical period for a newborn is the first hour of life. Okay, don't forget those 4 shunts that we had gone over before. They all have to close, and so blood circulation has to reverse itself. All right, and so that you don't want this baby while he's trying to breathe and trying to circulate blood. You don't want him to be cold. So write this down. Thermoregulation is so very important. Keeping that baby warm, and it's so important, especially in preterm babies. Preterm babies have a really hard time keeping warm. So it's our job to keep them warm. So you might want to, make sure when they come out, you dry them off real good, and you're going to stimulate them. You're going to dry them off, get rid of that wet blanket, put a cap on his head, and get and be warm. Also, let me tell you, I always have the radiant warmer in the delivery room on and ready to go before my baby's born. And because a lot of times the labor room, which is the labor and delivery room, it gets kind of chilly because mom was working hard while she was in labor, correct? Yeah. And so now we're ready to deliver. So it's this cold room. I don't want to cold stress this baby, because if you cold stress a baby, they're going to use a lot of their energy. So what happens to that? They get hypoglycemic on you. And then from there, they can go into respiratory distress syndrome. Okay, so keeping a baby to keep them warm, please do that for me. Okay, so another good question would be on bulb suctioning. Okay, so remember, you never put this little bulb syringe in the middle of his mouth, right through the middle. See me? No, because if you do that, you're going to start the gag reflex, which is his surviving reflex. So you want to make sure the bulb syringe goes on the side of the mouth. See here? Side, and then the nose. Mouth first, and then you go into the nares. Okay? All right. You always want to make sure that you have a patent airway, no matter what. Okay. Good deal. Okay. So again, here's your APGAR score. 1 minute and 5 minutes of birth. Each one of these is being assessed. You either got columns of 0, 1, 1, and 2. Okay. So 0, it means he didn't have any heart rate. Yeah, that's not good. Respirations, he's got no respirations. That's not good. And the same thing, this baby is what? This baby needs massive resuscitation. Okay. So you want to make sure that you're well versed on this and that you know what to do. Okay. Let's see. You always want to, if you see sternal retractions, it's not good. And I think you had a question on your quiz about this. And let me just see here. Yes. What symptom assessed in the newborn shortly after delivery should be immediately reported? And that, the main thing that's showing up, comes out the screen on me is sternal or chest retractions. Remember, those are never good. They must be reported immediately to the healthcare provider. Now, babies have a tendency to have blue hands and blue feet. Is not nothing's that's normal. That's called acrocyanosis. That's okay. It can happen for the first 24 hours of birth, but after that, it needs to be looked at for another reason, another problem with the newborn. So acrocyanosis. So if a daddy, say, walks into the room and he sees his baby and he's got bluish hands and bluish feet, and he comes out and he says, nurse, 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 I need you. What would be a normal reaction of the nurse? It would be, that's okay. That's normal. And for the first 24 hours. Okay. And remember, it just takes longer for that blood that's circulating in his body to get out to the peripherals. Kind of think about it that way. Kind of makes sense. So the middle of his like chest, his trunk, his head, they're pink. Okay. But his little feet and little hands are blue. Okay. All righty. All right. Let's go on here. You can look at this circulatory system, providing warmth always. Remember, babies are just unstable, guys, in producing their own heat. Okay, so they need someone to help them, and so you need to keep them warm. Okay, when you're doing an assessment on a baby, you kind of do things backwards. You know, I know everybody likes to start out with temperature for some reason, but you don't, not with babies, because once you put a thermometer under his arms, you know, you're disturbing his peace and quiet, and he'll probably cry. So I get the heart rate, and I listen apical heart rate for a full minute, and then I count my respiratory, and I want to make sure it's between 30 and 60. Okay. And I just make sure, because once he starts crying, everything's going to go up. His heart rate's going to go up. His respiration's going to go up. So I want to make sure that I get an accurate assessment. And also, another good question would be, like, when you're doing the assessment, you don't have to strip down the baby to see the whole body when you're doing an assessment. We do it in increments. So if I'm doing the right leg, I'm going to have him covered, everything but that right leg. Okay, do my assessment. I got my left leg, same thing. You keep the baby warm during the assessment. You don't want to, especially if you're doing an open crib, you don't want to cold stress him out. All right. This little one was about maintaining his temperature. So babies have a large head. Remember, I told you, cover the head. You want to prevent a draft from over the baby, because you lose heat through a term called convection. convectation. They can lose heat that way. So keep away from drafts. This one, by conduction, you can lose heat by conduction. If you put that little baby on a cold surface, such as the scales, and you don't put anything down, he's going to lose body heat. Okay, because the heat loss is by conduction. The scale is going to take that heat from that baby. And then don't put the baby near any kind of windows. Again, he loses heat by radiation. Okay, so again, just keep him out of drafts, you know, keep him away from the windows, which is better for safety anyway, I think too. And then of course the scale. Always keep the baby dry. Okay, so we wipe off that baby after delivery. All righty, because don't forget, see these babies, they're small, aren't they? They don't have a lot of subcutaneous fat to keep them warm. So again, they need you. Okay. All right, we're gonna move on. Let's see my next one. Okay, let's see here. Let's talk about, let me go here. Just know the average weight is from 6 to 9 pounds. If I had a baby over 9 pounds, what's that baby considered? The big baby. I think I have a picture. That's a macrosomic baby, isn't that? Macrosomic. Know that. Macrosomic babies, big babies. And so these babies are born, especially to moms who are diabetics. And they have a big problem at birth, everybody. They have the problem, once that cord is cut, then they're cut off from glucose from their moms, and they go into hypoglycemia, low blood sugar. Okay. Now, you don't want a baby going to low blood sugar, because that could also go into what? I said it before, respiratory distress. So I think you got the big picture. You got the picture of a newborn. Okay. These guys are small. Okay. Well, small. I mean, even a 9 pound baby, but they're small. They're small. They're small little human beings. They have a problem with thermoregulation, keeping their own body heat. They are products of their mommy. If mommy's a diabetic, then baby pumping got more sugar than it should have, and it's a big baby. So you got macrosomic baby. Okay. If mom took in drugs, oh, the baby's born with this neonatal abstinence syndrome. Okay, mom took drugs in. So when these babies are born, they're hyper. They're really irritable. So you got to swallow them. You got to, make sure they're all nice and tucked in. And they like low stimulation. They cry a lot. Sometimes you have to worry about them having tremors. And so sometimes they're put on phenobarbital because they can have tremors or seizures. That's neonatal abstinence syndrome. Write that down. Know that term. Okay. So if mom is sick, if mom has an infection, baby has infection. Okay, so baby's heart rate would go up during labor, and babies, when they come out and mom's been sick, babies can be sick. Okay. All right, let's go on to, how about we looked at the preterm babies? So let's go here. All right, where's my preterm? Here we go. All right. So this was a slide that I made for you guys, and it shows you the gestational age. Okay. Now, Ashley, because you are with me, be sure that you know the post-term infant. Okay, that's the definition, is between as 42 weeker. 42
My
weeker.
baby 42 weeks.
Yeah, I know that term. You got it. Okay, cha-ching, 2 points. Okay, so this is showing you the gestational age, okay? Because we do look at the infants and we can see exactly, where they belong. Okay. So if I was to ask you, which classification will the nurse assign an infant born after 42 weeks gestation, what's the correct answer? Post-term is B. Okay, 42 weeks. Be sure when you're looking at these kind of questions that you look at how many weeks gestation is this baby, okay? How many weeks? And so then if it's 42 weeks, you got a post-term baby. And they have their own problems, believe me, they do. All right, and we're gonna talk about a little bit what causes preterm. And multiples. A lot of times you're twins and triplets. I had a patient that had quads. I took care of her for a long time in the hospital, and then all of a sudden she went into labor. She was C-section, by the way. Placenta abnormalities. You can have placenta previa. Okay, the placenta is right over the internal os. Those are causes of pretermers. Okay, and then of course abruption. You can have a pretermer. So this is what a preterm looks like, and I hope that you were able to look at the story of Griffin. He's a 26-weeker that did very well. But this is your characteristics. So let's go over this slide real quick. Okay. So their skin. Their skin is really transparent. You can see they have very little brown fat because they're born really early. They have now remember the fine hairs is called langugo. They still have those hairs when they're born. And they have more, so they have on their shoulders and their forehead, because those hairs actually protect the baby's skin in utero. Vernix caseosa, which is your nature's cold cream, that is abundant. There's a lot of it on there. So when it comes to those kind of questions, you want to know, how many weeks are they talking about? How many weeks is this baby? Because a post-term baby, listen up, post-term baby has very little vernix. They used it all up. A preterm baby has a lot. Term baby has it underneath his arms, maybe around the folds of his neck, but not very much. Okay, and on a pretermer, the soles of the feet have very few creases. As you get older, you see more creases. Okay, and you can see I kind of highlighted
that. Hair is gone too on the post-term baby.
Pardon?
A lot of the sorry, what is the hair called again?
Langugo. L-A.
Yeah, a lot of that is gone as well in the 42 weeks.
Oh, 42, yeah. They use it all up.
My baby was 40. My last baby was 42 weeks, and he had like none. Like it was
that's right.
On there.
They used it all up.
My first baby was a lot of hair.
Yeah, they used it all up. So you remember something. When they're early, when they're preterm, they're going to have more because they're supposed to. Yeah. Term baby will have a little bit of a langugo on them. Usually you find it on like the ear, and maybe a little bit on the shoulder, but he's done. He's okay. He's ready to come out. A post-term baby, they used it all up. They shed it. It's in the amniotic fluid because they shed it off inside. And so that's amniotic fluid has all that kind of stuff in there. Okay, good deal. All right. So let's go over inadequate respiratory function. All right, so remember we had those, and we have the alveoli, which is your air sacs, and they have you have closure, they're closer to the capillaries in the lungs. This is all inadequate respiratory functioning. I would say on this, just know the preemies, the muscles that move the chest are not fully developed. That's what you got to know. And get this too, guys. If you got a preemie baby, remember surfactant starts only when? About 25 weeks gestation. Okay, that's when it starts developing because he doesn't need it beforehand. They don't breathe it. The lungs don't function in utero. But now he's going to get closer. So about 25 weeks, it starts producing. If you have a baby born at 27 weeks, he doesn't have enough surfactant in his lungs to adequately inflate them. Okay, you've got to have surfactant. Write that down. That's a really important term. I really want you to take note to it. All right, so you don't have that surfactant. So I'm going to give mom an injection, 2 injections of betamethasone. Okay, it's a steroid. And I'm going to give it to her 24 hours apart, because I want to produce, I want to get the surfactant a little booster. All right, makes sense. So I'm trying to get the baby now to make more surfactant in his lungs. Now, if she delivers shortly after that, the methasone, it might not work as well, but it's there. All right. But we try to get that in before the baby's born in order to give him a booster upper. Okay. Now, babies are born prematurely still have a tough time breathing. A normal term baby, guys, have a tough time breathing. So just think if he's premature, he's going to have a tough time. So he's probably going to go to the NICU. Okay. And remember, any baby that goes to the NICU, the parents are just devastated. All right. So a lot of support has to go to them. In the NICU, they're going to intubate that baby and they're going to put him on a machine in order that he'll breathe better. All right. We also give surfactant in a liquid form through the ET tube. Okay. That takes, write this down, that takes 72 hours to take hold. Okay. 72 hours. But they need it. You know, you cannot get away from it. Your lungs need this protein that makes those lungs go in and out, in and out, in and out. Okay. And on a preemie baby, remember that gag reflex I talked about, life-saving? Okay, very important for a baby. In a premature baby, that gag reflex is weak. Don't forget, it's all because it's immature nerve supply. Remember, reflexes come from the nervous system, the brain. Premature babies, the brain is still developing. Remember something, the brain develops all the way to 40 weeks. 40 weeks. That's why we don't do like inductions, say at 37 weeks, because mom wants to deliver on such a date. Nah, we don't do that. No. Because they found out, research has been very, very good about this, that the brain still is developing up to 40 weeks gestation. All right, let's see here. Let me give you another picture of my baby here. Yeah, then we did this one. Okay. All right. Another thing I need you to know. Okay. Oh, this is my slide on surfactant. Okay. Yeah, we went over this already. Okay. Very, very important. All right. Now, we have to be very careful of how much oxygen is being given to a preemie baby. Very important, guys. We have probably in the past over-oxygenated a lot of babies. We can cause the baby to have bronchopulmonary dysplasia. Write that down. Write that term down. Bronchopulmonary dysplasia. You spell that as BRONCHO, bronchio, pulmonary, PULMONARY. That's all one word. Okay. Dysplasia. DYSPLASIA. When you over oxygenate an infant, you can cause that dysplasia. Not good. So what do? I put a pulse oximeter on my little baby, and I'm watching his oxygen concentration, saturation rate. And if I get a reading, now write this term down because you're going to see this one again. If I get a reading of 92% or higher, I'm fine. Babies are fine at 92% or higher. Okay. So that was a good one to know. All right. when you have a baby with respiratory distress, I'm going to hear maybe some grunting sounds. Grunting. So put down RDS and put down grunting sounds. Not good. You know, he's trying to pull. I can't breathe. Nasal flaring in a baby is never good. Nasal flaring. Sternal retractions, we talked about that, or intercostal, the ribs pulling, never good. Of course, cyanosis would be another indication. Again, as long as if he's completely cyanotic, he's got a problem. All righty, good. Remember, you can see this is pretty important. The surfactant we went over. If you cold stress your baby, you can decrease the amount of surfactant. Not good. So you don't want to cold stress a baby, because if cold stress the baby's trying to keep himself warm. So he's going to use more what? More oxygen, more energy. And so he can use more energy, he'll use more sugar, become hypoglycemic. He becomes hypoglycemic, he can go into respiratory distress. Not good. Another thing that
And this causes him to lose weight.
Yeah, they can lose weight very quickly, actually, because you don't want to cold stress a baby. They use too much of their energy to keep themselves warm. Hypoxia also uses a lot of surfactant. Well, that kind of makes, if he has low oxygenation, sure. And poor tissue perfusion will also. So you want to keep this baby. We have a picture. I want to keep this preemie baby what? I want to keep him stable. I want to keep him warm. I'm going to have him tubes. I probably have an umbilical vein line in him. That's why with a preemie baby, when we cut the cord, guys, we leave a good amount of cord, because that umbilical vein is very huge. It is lovely. It's so nice to put an IV line through that umbilical vein. Because can you imagine trying to put an IV in a preemie baby? It's very difficult. So if you got this beautiful umbilical vein, I can put that line right in there. So we got that. Okay. All right. So what's your nursing care of a baby with respiratory distress syndrome? We'll monitor him, that's for sure. So I've got him all kinds of monitors, especially my pulse oximetry. I want to make sure that my oxygen is just right, 92% or higher. I don't want to give too much. I talked about this earlier, I guess last week. I talked about cluster care. That means what you're doing is everything you're going to do for this baby, you bring with you. Okay. So I got my care. I know what I'm going to do for this baby. So I want to have everything, because when you touch a premature baby, that baby, you're stimulating that baby. And that baby then uses a lot of energy. Okay. Because he doesn't know who's touching him. He gets nervous. He starts to produce, and he's scared. So he uses a lot of energy. So you don't want to do that. You want to conserve energy, because he needs all the energy, what, to grow, so you want to make sure that you do everything in one sitting. Can you imagine you have a preemie, you have like a 2 pound baby, and you say, okay, well, I'll do this, okay, I've done that, and then leave the baby, so now the baby settles back down again. She's gone. Okay. Then you come back shortly after that, and here you touch the baby again. The baby goes all over again, has to wake up. He's using more energy. Okay. It's repetitive. This poor little thing needs to what? Sleep. Needs to sleep and grow. So you need to leave him alone. You're always assessing your babies, but you're not always touching your babies. Okay. And then again, monitor oxygen. All right. So, because if you don't, you can cause this. So this is a slide on bronchial pulmonary dysplasia. So what it is, it's just a toxic response of the lungs to too much oxygen. Okay. Yeah, you can blow out the lungs, you have atelectasis, you have edema, you have thickening of the membranes. And so, and it can cause some really long-term complications such as the retina in the eyes, too much oxygen. So want to make sure I got a pulse oximeter on and keep that at 92%. Okay. All right. Apnea in the preemie is right there because he's immature. So what it is just immature of the nervous system. So even they go home on an apnea monitor. Once a preemie grows and now they're ready to go home, they can go home with actually this apnea monitor, because what happens, they may get some bradycardic and then they stop breathing and then they get cyanotic. So this monitor, you put it around their little chest and you hook them to a machine and then they sleep. Now the machine will buzz, will make a noise, pretty good alarm, and let the parents know that this baby had apnea. All right. Here's my slide on saturation level of 92% or above is normal. Okay. Let me see here. What else I want to go over with you with the preemie. So be sure that you know premature care. Okay, let's see here. So if I ask you this question, the nurse is assessing the pulse oximetry of a preterm infant. Which of the following indicates a normal reading? Anybody? Is D. Oxygenation saturation level of 92% or greater. All right, we don't want this baby to get septic. So what am I going to do? Standard precautions. Remember that. Wash the hands. When people come in to the NICU, like mom and dad, they must do a full scrub of their hands. Okay. And we usually have their hands and they can go up their arms even. And then a lot of times they'll have on a gown, especially if it's a real small baby. Okay. Because why? Because everything is immature. The liver's immature. He has very limited formation of antibodies. And so we don't want this baby to have a sepsis. Sepsis can kill a baby. So because they get low temperature, they get lethargic, and they're poor feeders, and then you have respiratory distress. Never good. Okay. Just as a term baby can have problems with poor controlled body temperatures, what do you think a premature baby has? So you want to make sure you keep this baby. Okay, good. All right. All right, so this is pretty good to know. These are signs and symptoms of cold stress. I would know these guys. So it could be all that apply. Question. You have decreased skin temperature. Baby's gonna be cold because you talk about cold stress. So we got decrease in skin temperature, increase in respiratory rate. I'm trying to keep myself warm, so I'm going to increase my respiratory rate because I'm trying. I'm a hard time. His skin, they call modeling of the skin. It's like all different types of coloring on the skin. That's never good. Okay. And then of course his heart rate will go down, bradycardia, because he's working so hard with his respiratory rate, and the kid will be very, very lethargic. So this is cold stress. So remember I said you don't want to ever cold stress a baby? Exactly why. Okay. So we've gone over now newborn respiratory distress syndrome, newborn apnea, oxygen therapy for preterm infant. We've gone over bronchial pulmonary dysplasia. Okay. We've gone over post-term infant and preterm infant. All right. All right. Be sure, if I don't hit upon it today, be sure to go over, look at male circumcision, know what's normal, okay, on the circumcision. And let me see here. I've gone over cold stress, reflexes, pain assessment. Okay, all righty. Let's go on to some chapter 14. As you can see, we're going through the different chapters. All right. So now we're going to go hit upon chapter 14, which hit upon cleft lip, cleft palate, and let's do that. All right. Hang in there. We're almost through. All right. Okay. So let's hit upon, let's see. Our first one I want to go over would be hydrocephalus. All right. So hydrocephalus. Here we go. All right. So, hold on. Thank you. Okay. So if I was to ask you what is hydrocephalus, you would tell me is what? Increase in cerebral spinal fluid. Okay, so now chapter 14 has to do with perinatal injuries and what? And problems, malformations of babies. Okay, so this here with hydrocephalus, it means that the neural tube defect didn't close properly. So now we're going to have a problem with in the brain where the ventricles are not absorbing the cerebral spinal fluid. And so it causes the head of the baby to get huge, very large head. Okay, very large increase in head size. Okay, and it's just because it's a malformation. So these babies, maybe mom had an infection or maybe has an infection. Maybe she had a perinatal hemorrhage. Or there's an obstruction. Something went haywire. That's what I always say. So unfortunately, then the baby then has this big head. Now, what normally is a good question is concerning nutrition. Nutrition is a problem with hydrocephalus, because these babies are so big, the head's so big that it's hard for them to lift up, hold up. So for nursing, nursing has to what? Position that head during feeding. So nursing has to support the head during feedings. All right. So if I was to ask you a question, which assessment finding will the nurse expect for an infant diagnosed with hydrocephalus? Would it be a protruding tongue with a short, thick neck? Would it be a large and rapidly growing head? Would it be inward turning of the ankle and foot? Or would it be a hairy patch in the lumbar sacral region? Which one of those is hydrocephalus? And if you would answer 2, you were right. It's a large and rapidly growing head. Okay. Now let me tell you, protruding tongue with a short, thick neck is a Down syndrome baby. You need to know that. An inward turning of the ankle and foot, that's a club foot. And then there's a little hairy patch in the lumbar sacral region. That is spina bifida occulta. Okay. So those are good questions that could be asked. So for intracranial pressure, you're going to see bulging fontanelle in the infant. That bulging fontanelle. And going to be, he don't feel good. He's going to be a poor feeder. Children who have problems would be poor feeders. And that's why nutrition is a problem with these babies, either with spina bifida or hydrocephalus. They have problems with nutrition. Okay. What's your treatment? Well, putting a shunt in would be the treatment. Okay. So here is the shunt. See here? So here's your ventricle on the brain. So this ventricle is not operating correctly. So that cerebral spinal fluid is not being absorbed nor drained. So we put the shunt in, and this will help take the fluid out of here and put it into the peritoneal cavity. So you've got the shunt in the ventricle, goes behind the ear, as you can see, and it goes into the cavity, peritoneal cavity. This is what called a pump. And the doctor will write the orders as to how often the pump is actually pumped, okay? In order that we get the fluid out of the ventricle. Makes sense. All right. This is put in babies, and again, the head is, we want to relieve the pressure in the brain, and it has this shunt has to be done over and over again as babies grow, and that kind of makes sense. So, you want to make sure that you position the head and position the baby. You don't want skin breakdown. That's with any kind of patient, guys. If you have lay a patient in one position for a long time, like 4 hours, the pressure on that area will break down the skin. It makes sense. So you want to have frequent changes. And with this, the head has to be changed because the head is heavy. All right. The head has to be supported at all times, especially being fed. Okay. You can't try to feed a baby and his head's like, well, I really would like to suck, but I can't because my head is heavy. Help me, nurse. So again, you have to think this poor baby's got to have support. And then in your assessments, you're always going to measure the head circumference. So you're going to do all the vital signs on this baby because you want to ensure that is it growing or is it getting better? Especially if it's pre-op, what's the size of it? Very important because then you're going to compare it post-operatively, all right? Because after he has the shunt put in, then you're going to look for is this shunt functional? Is the head circumference, is it going down? You want to know that. I want to, and again, I have to keep this baby from getting infection. And it's really, really important. They do get infected very easily. So you've got to make sure that you get, keep the baby from getting infection. Again, hand hygiene, washing, standard precautions must be followed at all times. Okay. And then again, you get your doctor's order and he'll tell you how to pump that shunt. Okay. So, that's what I want you to know about hydrocephalus. Okay, let's go on to spina bifida. You got 3 different types. And what you want to remember from this is that, let me go back to my drawing here. Okay, here. You have to protect the sac. Write that down. On spina bifida, babies, children, you have to protect the sac. This one is the meningeal myelocele, which is about the worst because you can see the meninges. They're in the sac. Can you see that? Okay, let me make it a little bigger for you. So you can see here, you've got the meninges that are in the sac. Here's your spinal cord. See the spinal cord coming out? This is not good. So folic acid, we talked about that, how important it is. This is the reason why taking in folic acid, either pre-conception or the very beginning with the embryonic stage, development stage, this is why. Because you don't want a baby born with an open neural tube defect. So your child, this baby has one, you're going to nurse is always going to protect the sac. So I get a sterile towel, I put sterile saline, and I make it wet, and I put that around the sac. Anytime you have an organ that's outside of the body, you must keep it moist. It doesn't matter what it is. You must keep it moist. Otherwise, it'll dry up and it'll die on you. This one here is the meninges are coming out, but the spinal canal here is not. So you see the difference? The meninges, here's the protrusion, but the spinal cord is intact. Okay, this is your worst kind. These are children that have a problem with bowel and bladder functioning. Okay, now this one is your spina bifida occulta. This is where You can't see it on the outside, but you know what? That little tuft of hair is just right there at the spine, right there in the sacrum area. You can see it. And sure enough, that's the occulter. So then you're going to investigate, probably do an MRI to see more. Okay. So those are the different types. Again, it occurs during the embryonic development stage. All right. So let's see. Here's your little tuft of hair. See here? This is what you see. So when a baby comes out, we are really assessing everything, as you can tell. All right. Okay. So let's jump down to my next topic. And that would be a cleft lip. So let's go down to cleft lip. Okay, you have all these PowerPoints, but I send them all to you. All right. Well, here's a little brain teaser. Let's see what this brain teaser is. The nurse is caring for an infant born with spina bifida, myelomeningeal seal. Okay, that's the big one. So which intervention will the nurse implement to protect the sac? I'm going to cover with a sterile cloth moistened with sterile saline. All right. Let's go to cleft lip. Here we go. All right. So on this one, the cleft lip is characterized by the fissure opening in the upper lip. All right. Okay. So what happens is the maxillary, the medium nasal processes, they don't come together. Okay. It's during the embryonic development time. Okay. Again, so important that embryo stage, which goes from what, week 2 to up to week 9, right? And from that's the embryonic development time. Okay. Most people don't even realize they're pregnant during that time. All right. So here's our little cleft lip. Okay. Now, what I want you to remember from this one is that we can do surgery. Nutrition is another factor with this baby, because they're going to need a special bottle, okay? And because poor little guy, he can't really suck, can he? Remember that reflex sucking? He really can't do it very well. So you're going to need a special bottle, and we're gonna fix it. Now, when we fix this and we bring this tissue together, we don't want him to have a very, bad scar, because he's going to live with this for the rest of his life. And you can really tell when somebody's had a cleft lip when they were young, is you can see sometimes that scar. You want to really got to heal nice. But how are you going to heal that when you got a baby? Well, you got to make sure that he doesn't take his little fingers and scratch it, because sutures do get dry and they do cause itching. So you got to make sure that he keeps away from that. Now, the repair is about 3 months of age. All right, so that's why you have to have that special bottle, syringe to help feed him. All right, because again, he can't suck. Okay, so your post-operative care is to prevent this infant from sucking and crying. Oh, now most babies, that's how they communicate, is through crying. But you don't want them to cry because you want to get that sutures together. Okay. And you can't have them like, sucking like on a pacifier or anything, because you want the suture, again, the lip, to come together really nicely. I want to prevent infection. Anytime you got a patient that's had surgery, that's one of your biggest nursing diagnoses, prevention of infection. And then, and you want to apply gentle cleansing of the suture line to prevent the crust from forming. You really want to worry about that suture line. Now, babies need love. There's no doubt about it. Because this baby's going to grow up, and we want his psychosocial to be good. So they need cuddling, and they need, a lot of cuddling, holding them, because the cuddling is like a form of affection. So they got to know that they're loved. Okay. All right. So you may have to feed them until the wound is completely healed, about maybe 1 to 2 by a medicine dropper. Okay. Got to take a lot of patience. That's why you got to really support these parents, because it's not easy. And then you cleanse the mouth. Once you give a food, you don't want anything residual left in the mouth. So you want to keep that all that clean. So you're going to cleanse the mouth after feeding. Now, the other one we're going to talk about on my list is cleft palate. Now, what I want you to remember about a cleft palate is because that palate, which is the hard plate on top of your roof of your mouth, that didn't come together again during the 7th to 12th week of gestation. So what happens is that these kids, because they have an opening, they get a lot of infection in their respiratory tract and middle ear. Remember that. Middle ear. Write that down, everybody. Middle ear infections from a cleft palate. And I tell you, if you ever had a baby with a middle ear infection, they are uncomfortable. It's not fun. And they have a tendency to get a lot. And so we're going to have problems with teeth, speech, feedings. This one also with nutrition is a big problem. And then just their own self-image as they grow up. So you're going to bring the cleft palate together, which will improve the feedings, which will improve his speech. But he'll need probably a speech coach, therapist. The dental, he'll need probably pediatric dentist and orthodontist. Because what happens with the teeth, because the teeth buzz, all the babies are born with teeth buzz. With a cleft palate, they're not going to come in correctly. So even though you're going to bring that together and make it better, they're still going to have teeth problems. And again, this is your multidisciplinary team that I talked about. I also agree with this. I also would do a social worker in there to help the parents, because there are support groups and there extra help out there. Because these all pediatric dentists, orthodontists, expensive. Speech therapy is expensive, and maybe a psychologist. So they're going to need help. They're going to have to know who can help me. And of course, a pediatrician. Alrighty. Now with they usually have the surgery for the cleft palate between 1 and 18 months of age. So don't forget, you're going to have problems with middle ear infection and feeding, because these kids are going to be surgery. They're going to be 1 year and 18 months. All right. All right. This could be a really great test question. On these kind of kids, there's no food given through a straw. No food through straws, because you don't want them to suck. Remember, I talked about that. No sucking. We talked about oral hygiene. We talked about speech. And it's really hard because you don't want them to cry. So, you got to keep them entertained quite a bit. It's not easy. And I remember here, I got again, complications, middle ear infection, and teeth. They have a lot of tooth decay. The teeth just die off. All righty. Let's go. My next one I have on my list is club foot. Okay. So club foot means that it's abnormal. Let me showing you here in the picture. Remember, see here, the foot is turned inward or outward. Inward and outward. See? So we got here. Let me see if I said that right. Turn inward. Yeah. Okay. It's inward or outward. I was right. Okay. All right. So I've seen the babies where they have their feet turned inward. A lot of breeches have this kind of problem. Is because the way they're situated, and their feet have a tendency to do this in utero. And so then they're born with the club foot too. So what am I going to do? All right. So I got to maybe do some conservative treatment. Remember, it's always better to go with the lesser. Then if that doesn't work, such as maybe splinting or casting the baby, then we may have to go to surgery. Okay. Again, you want to do this. Now, these kind of kids, you want to do it as soon as possible. Because why? Because bone and muscle will continue to develop, see? So when that happens, and they're turned inward, that's how they're going to keep developing. So I got to get them as soon as possible, and I'm going to try to bring that foot straight. So how am I going to do that? Well, I'm going to put them in a cast. So you have to put a cast on these kids. Now I'm going to tell you, I know one of my good friends had a child born like this, and they tried everything they could with casting and everything, but they did eventually have to have surgery, and after surgery they put her back in a cast, and it lasted for the first year, her first year of her life. But you know what, guys? She's doing fabulous now. Doesn't have any special shoes and running and jumping like you wouldn't believe. It does work. Okay. All right. All right. The main thing about about casting is you want to prevent skin breakdown. Okay. And so, you got to be careful with casts because children have a tendency to put their toys down their casts. So you gotta be careful, and also you want to always look at the color of their toes to make sure everything's okay. All right, let's see here. Let's just go over this. You might see a question on this one about the gluteal folds. Okay, so this is your hip dysplasia patients. So here on these, you have the gluteal folds are not symmetrical. Okay, one is higher than the other. This one here has this provider here is doing a Ortolani test. And when you take the leg and you bring it back up, which would be adduction, you hear this clicking, and that's the femur should go into the acembellum. And when it clicks, that means it's not in there. So that is hip dysplasia. And and so here it is, like what I just said, the head of the femur is partly or completely displaced. Yeah, okay. And I think this slide did I do that? No, here. So here you go. So it's limited abduction of the leg on the affected side. Again, you hear that clicking, and what you got to know is that the head of the femur is not going into that socket. Okay, into the acembellum. That's what that's called, the acembellum. It doesn't go in there. All right, let's move on here. Here I did have the Ortolani sign or clicking, and they can usually hear you, and you really can feel it too, where the slits back into acembellum under gentle pressure. You can actually hear it. So that's not normal. We shouldn't be hearing that, and so it's got to be taken care of. All right. So how are you going to do this? You put him in what we call a pelvic harness. And what you're doing is keeping him in a position, okay? And so you want to make sure that his little hips, okay, are in constant flexion and AB duction for 4 to 8 weeks. What they're trying to do is they're trying to keep the head of the femur within the hip socket. Remember I said it's not normal for that to come in and out of the acembellum. So by doing that, keeping them in this constant flexion, it keeps that pressure, constant pressure, and so it actually it enlarges and it deepens the socket, the acembellum, so that the head can get in there and stay there. Okay, not easy. This is what a pelvic harness looks like, and it's not the easiest thing. See how his hips are abduction, abduction. And this little girl here has got a cast on her, and it's not easy. And you got to make sure that you can assess the, of course, the peripherals here, and make sure that she doesn't put no toys down. So you don't want to give her any little toys, so she can do that. Here, this little guy, looks like a little girl here. She's in a wagon, and they position them here with pillows. Again, you can go around. You got to keep these kids stimulated. It's not the easiest thing to do. All right. All right. All right. Anytime you got a spiker calf, excuse me. Oh, I already said this twice. I already told you this. Sorry. I was ahead of myself. All right. I want to go into some metabolic defects. You'll probably see one on PKU. It's a big one, PKU. So, first one, write down PKU. What happens is you have faulty metabolism of phenolphthalein. Okay. Now, phenolphthalein is an amino acid that is essential to life, and it's found in all proteins. Protein. All right. So, in order to know if this baby is able to break down this amino acid, okay, he has to have protein. So, this test must be done 48 hours or greater. You can't do it before 48 hours because this baby hasn't had protein. So remember that, because that's a good test question. So you have to have from 48 to at least 72 hours. So sometimes these babies, we always get them before they go home. So if mom is staying 2 days, right? So that's 48 hours. The baby has enough protein. We do we do the Guthrie test. That's Guthrie, Guthrie test. And that's a blood test. That's a specialized blood test. So you draw the blood out of the baby's heel and you put the blood, and it's got to be within the little circles. Now, believe me, if you've been in the hospital and had any kind of exposure to this test and you didn't do it right, the nurse is going to say, that's a faulty test. It has to be just perfect. Okay. And so we're going to test that. And if we find that the child cannot break down this amino acid, phenolphthalein, this child can never tolerate protein foods. Okay. It's a very important test because, and every child gets it, it's mandated in all states because it's easily picked up. And if you don't pick it up and you continue, this child can be severely retarded in a very short time. So that's pretty important. Okay, so that's your PKU test. And these kids have that musty odor to them. Child has a musty odor. So you've got to pick it up. You've got to. And we do blood because by the time that this phenolphthalein accumulation shows up in, say, the urine, you already got brain damage. So that's why we do blood tests. So again, blood tests are very, very important. Okay.
I'm sorry. I have to leave for my med surg shooting, but thank you for the review and I'll finish it later.
Sure. I'll continue. And thank you for attending.
Thank you.
You're welcome. Okay. I'm going to continue now. Again, I said the Guthrie test, and it has to be within 48 to 72 hours after birth. Wait, said that. Okay. All right. These babies are on a substitute formula. It's called lofenalac. Lofenalac. And it's Lofenalac. Okay. It's a dietary management. Because they're going to grow up. They just cannot tolerate protein. So if you can't tolerate protein, then you're going to have you're going to maybe you got to teach the parents how to read the food labels. And you may have to refer this family unit to a dietitian. All right. Also, another tidbit, it probably won't be on the test, but children with PKU have to avoid that artificial sweetener, aspartame. You've heard of that, which is NutraSweet, because when it converts to phenolphthalein in the body, it converts to phenolphthalein in the body, which is not good. Okay, let's go on to maple syrup. And is called maple syrup because, again, it's a defect in metabolism of a chain of amino acids, just like PKU, right? Okay. So you have these serum levels increase of leucine, isoleucine, and valine. And what happens, they can go into ketoacidosis. And what also, you get cerebral degeneration and you get death within 2 weeks if not treated. Okay, pretty important, I would say. So these babies, just like your PKU babies, they appear healthy at birth. No problem, right? No, the problem will soon develop. They have feeding difficulties. You know that moral reflex, one of the reflexes, okay? They lose that's the brain. They lose that neuro. Hypotonicity, they have low tone to their body, irregular respirations, and they can convulse. So what do you see in these kind of babies? Well, in urine, sweat, and earwax, they have a characteristic maple syrup, which is sweet, odor. And I said before, it was caused by ketoacidosis, which also gives them a fruity odor. Okay. And I know you can equate that to a diabetic. But again, earwax, sweet smelling, maple syrup, not good. So, well, how are you going to treat this? Well, you have to remove the amino acids and their metabolites from the body tissues. So lots of IV fluids or hydration, and maybe they have to go into perinatal dialysis to decrease the level, the serum itself. I mean, the amount in the serum. Okay. Lifelong diet, low in amino acids. Okay. These kids, if they get an infection, it can be life-threatening. All right. The next concept that's on my list is lactosemia. All right, so here we are. So what happens? The baby's unable to use glucose and lactose, sugar. So you have an enzyme that's needed to help the liver convert lactose to glucose, and that enzyme is missing. Remember, these are errors of inborn metabolism. So what happens is that you have an increase in serum lactose levels, which is like lactosemia, okay, in the blood. And you can have it in the urine. That would be galacturia. Okay. And since galactose is present in milk, is in the form of sugar, therefore early diagnosis is essential. It has to be. So if you find a baby that has lethargic, is acting lethargic, is maybe vomiting, has a low tone. You saw that in the other ones too, low tone, diarrhea, and these babies have a failure to thrive. They don't grow such as a regular newborn. Okay, so what are you going to do? So the milk and lactose containing products are eliminated from the diet. Unfortunately, breastfeeding must be stopped because there is galactose in the breast milk. So what do you want? You need to have lactose-free formula or soy protein-based formulas. And then again, parental support and education is essential. All right. Down syndrome is my next concept. It's the most common chromosome abnormality. The risks increase with mothers being 35 years of older, because remember, that's advanced maternal age, and daddy's sperm gets old around age 55. It ranges from mild to severe, and then some physical abnormalities are also seen. Now, these are there's some phenotypes here. So trisomy 21 is most common. And there are three number 21 chromosomes instead of the usual two. What happens is that, your chromosomes, they look like this, right? Okay. What happens is that when the production of chromosomes was, they're splitting off, this one didn't split off. This one stayed. So you have a trisomy. What I want you to remember is the test that's used to diagnose Down syndrome is called an amniocentesis. An amniocentesis is the most accurate. You can have the alpha-fetoprotein test, which can be done around week 15, but that has a tendency to give out some false positives. Well, you wouldn't want to do anything drastic to the pregnancy if just based on an alpha-fetoprotein test. So that comes back abnormal. Then your next line to diagnose the problem would be an amniocentesis. And you can see here, this is the manifestations of a Down syndrome. You have the simian crease here, the short finger, and you have the protruding tongue. You can see the low set ears and the eyes, and they have a flat nose. Okay, these children are kind of limp. They have, again, hypotonicity. That means low tone to their muscles. So therefore, they're not able to maybe hold their head up. They're difficult to hold into position. And because of the low tone, a hypotonicity, they have respiratory illnesses and constipation. Okay. All right, let's go on here to erythroblastosis fetalis. All right, or we can classify this concept as the hemolytic disease of the newborn. Remember, we want to know mom's blood type, because if she is Rh negative, that's like a red flag, and we have an Rh positive daddy, we have an Rh positive fetus. And remember, maternal and neonatal blood, they shouldn't mix, okay? They need to stay in their own little ways. So here is my beautiful diagram on this. And you can see here the red blood cells of mommy. See, she's negative. Now, a lot of you guys, I've noticed, either on the last test or a quiz, you put RH, mommy's RH positive. No, listen to me now. It's RH negative moms, and you have an RH positive fetus. That's the problem. So here you have Rh negative, and here you have the positives. Okay. Now, when these two mix, we don't want them to mix, but sometimes they can happen. Then what happens, the mom makes these antibodies. See these antibodies? They're like, and they're going to go in here. They're going to cross the placenta, and they're going to go in here to this baby, and they're going to kill off those beautiful red blood cells or erythrocytes of the infant. When you do that, you're causing this baby to be anemic. And babies can sometimes have to have uterotransfusions. And that's very risky to do that. So what can I give mom to make sure that this doesn't happen? I can give her Rogaine. Okay. Let's jump over here. All right. Another problem too with erythroblastosis is that it can be confirmed by an amniocentesis. We're going to go into the uterus, into the amniotic sac, and we're going to get a sample, and we can monitor the bilirubin levels in the amniotic field. Remember, when mom's antibodies cross over and kill the red blood cells, that can cause this baby now to have increased bilirubin, which is never good either. Okay. Hold on just a minute. There we go. All right. So, what are we going to do? So, then we're going to have a problem at birth where the infant is going to have pathological jaundice. Remember, pathological jaundice occurs within the first 24 hours of delivery. The liver is immature, so it cannot handle the amount of destruction or hemolysis of the red blood cells or the increase of bilirubin levels. You just can't handle it. So then you have this child now having an enlarged liver, enlargement and edema of the liver and spleen. This is not good. So by giving mom Rogaine, I can prevent something like this from happening. Okay. All right. Because this baby not only can be severely anemic, as we talked about, but also major risk for shock or heart failure when it's born. All right. When you have a increase in bilirubin circulating in the blood, it can go to the brain. And that's a condition called kernicterus. Kernicterus, Kernicterus. That's when bilirubin levels get to at a serious level. Never good. These kids are sick and they can have brain damage. Okay. And so these kids are usually very irritable, lethargic, poor feeder. They have a high pitched cry. A lot of babies, when they get sick, have a high pitched cry and muscle weakness. So that would be going toward, again, hypotonicity of the muscles. And they can have seizures. These babies can be very sick. So we have to intervene when you have this kind of baby. You want to do prompt identification, laboratory testing, phototherapy, and exchange transfusions if indicated. All right. So when we talk about what we're going to do, we're going to have to put this baby under phototherapy. Again, when you have a baby under those Billy lights, and they're very concentrated lights coming on this baby's body, you have to protect the eyes from that light. Okay. Make sure that baby's feeding well, getting fluids, because when you give fluids, what? The baby will excrete it, and they excrete bilirubin through their feces and their urine. Okay. And then again, you always want to monitor and make sure that is happening. His newborn color is getting better. We do laboratory tests. We'll do bilirubin levels. Okay. And so we want to make sure that this baby has a fighting chance. So we're going to put him again under the phototherapy. Okay. So jaundice that occurs on the first day of life is always pathological. Okay. And it requires prompt intervention, guys. Okay. Physiological jaundice occurs within those first days of life, from 1 to 3. Usually about day 3, day 2, day 3, you start to see a little discoloration on the nose, You press against a bony prominence, and sure enough, when you let it go, you see yellowish tinge. Prompt intervention. All right, hold on just a minute here. All right, so went over that already. What's my next concept? Let's hit on meconium aspiration syndrome. I had a picture of the phototherapy here too. And you can see bright lights, okay? Baby's laying there naked, maybe a little diaper on, and had protect those eyes. Protect his eyes, okay? All right, let me go on to, let's see if I have meconium aspiration syndrome. Okay. What happens is that the baby had his first bowel movement in utero. The first bowel movement is called meconium. It's a real thick, tarry looking stool. And he can have it in utero if he's in some kind of distress. We don't like it to happen, but it can. So what happens at birth is that when the head comes out, you want to suction this baby. Okay. We don't want this baby to take his first breath. So we'll do deep suctioning right as the head is expelled. Okay. The next contraction, the rest of the baby's body comes out. Okay. Then we take the baby and we not stimulate this baby. Okay. And we take it over to the radium warmer. We put the baby under the radium warmer. Again, going to cold stress this kid out, put him under the radium warmer. RT, respiratory therapy, will be in the room, and your NICU nurse, okay? They will intubate the baby, and they will go deeper and suction this baby, okay? They'll get as much as they can. They may do it a couple times. The nurse, she's palpating the umbilical cord. She's checking the baby's pulse. She can do that with the umbilical cord. So she's tapping her finger to tell RT we're okay. Because don't forget, whenever you're going down, I'm going to cause the baby, maybe his heart rate to go down. Okay. So we have to be very careful what we're doing. So she's saying we're okay. Go ahead and do a second downward motion. Suction out. You come out suctioning, okay, in a circular motion. And now we got a whole bunch of meconium out. Now that baby is going to start to move around because he's going to say, what the heck's going on? He may start crying. What we're trying to do is keep him from aspirating his own meconium into his lungs. We don't want that to happen. And that's why we want to do. Because don't forget, meconium is thick and tarry and it has toxins in it. And it's not good for babies because babies can get very sick from meconium aspiration. And they're being in the NICU a long time. All right. It's never good. Okay. Now, on this slide, I did show you the symptoms of meconium aspiration syndrome, which would be respiratory distress. So this kid's got to aspirate on this. He's going to get really sick. He's going to have respiratory distress. Those nasal flaring, boom, boom, right there. Retractions, his chest going in. Trying to breathe. I'm going to be blue. I'm not going to have circulating RBCs, oxygenation going on. I'm going to be blue. Grunting. I'm in bad shape, nurse. I'm making grunting sounds, never good. And when you listen to his lungs, you may have rales and rock eye. And then tachypnea. They ever said these kids are sick. You can have tachypnea periods for several weeks. Not good. So what's going to be my treatment? Well, first of all, I'm going to, in the delivery room, going to have RT, respiratory therapy, and an ICU, the neonatal ICU nurse. Okay, those are my teams. I'm going to have the radium warmer. Okay, it's got to be on, reducing the heat, getting ready for the baby. Going to have oxygen. Okay, ready, blow by oxygen for him. I'm going to have supportive care. And he's going to go right to the NICU. Okay. Again, going to have an IV. So again, remember I told you we leave extra cord? Yeah, we leave extra cord when we cut. Is because whenever you have a sick baby, you're going to leave extra cord because that umbilical vein is big. It's lovely. You can put a beautiful IV line right through that umbilical vein, and you don't have to worry about trying to get an IV started on a baby that's sick. Okay, so you kind of get the picture of this baby after it's born, and it's not good. Okay, you want to make sure that you take care of it. All right. I do want you to make sure that you're well versed on neonatal abstinence syndrome. This is caused by fetal exposure to drugs in utero. Yeah, mom takes in drugs. It goes cross placenta straight to mom and can cause baby then to have this. The baby's actually getting that cocaine or marijuana or heroin. Whatever mom took in, it goes to babies. It all crosses the placenta. So the baby then will be addicted to the drug because he's used to it. Okay, and that's what addiction is. He's used to it. And so his body, when he's delivered, he gets cut off. He's like cold turkey. And so his body is looking for that. And it might not be there. Okay. It's not there. He's cut off on mom, right? Yeah. So what happens, we have a baby addicted that's going to go through some long-term development and neurological problems. Yeah, never good. Okay. So these babies, now, if you're not familiar with this, I want you to write this down. These symptoms are, they can have tremors, body tremors, hyper irritability. That's your primary sign. They're so hyper, guys. And it's really sad to see a baby that's crying, that's has all these body tremors. It just involuntary, just body just goes through all this. They're awake, they don't sleep. They can have massive diarrhea. They are poor feeders. They're looking for the drugs. They don't want to eat. Poor feeders. And sneezing and yawning. Now I've seen that wallet applied question on tests. It's a good test. It's a good question. Okay. Remember, when a person goes through, even an adult, when they go through withdrawals, what do you what have you seen like in the movies, or maybe you dealt with mental health, you dealt with a patient who was an addict who's addicted. When they're trying to come off the drug, what do they look like? Well, they have the same things. They have body tremors. They're hyper, you know. Sometimes they pace like like a lion in a cage, because they're just pacing. They can't settle down. They can't sleep. They also have periods of diarrhea. Okay, the body is just trying to excrete stuff. They don't interested in eating. No, they're not interested in eating because they want the drug. Okay, so again, these adults and babies, they go through the same stuff. And it's so sad to see this. So how are you going to test the baby? How are you going to pick up the drug? I tell you what, the best way is to test the meconium stool when the baby has its first bowel movement, and that's called meconium. You want to test in that. Okay, it's more accurate than say in the urine. All right, so it would be more concentrated in the meconium. Treatment. I highlighted this for you because this is the treatment. They want to swaddle them, swaddle those babies. SWADDING. Swaddle those babies. Wrap them up real tight. These children need a quiet environment. You don't want them being in a room with 10 other babies. They need to have their own quiet environment. You always, as a health nurse watching this baby, you're watching for seizures, because these babies have a tendency to have seizures. Therefore, we put them on phenobarbital to help with that. Okay. So you can see how under NAS would be a couple of good questions on this. So if you don't know it, write it down. All right, now let's go over the infant of a diabetic mother. All right, so again, large amounts of glucose are transferred to the fetus in utero. Hey, I'm in here, mom. Give me those Snicker bars every day, okay? That's what it's like for that infant in utero for a diabetic, a mothers who are diabetics. Okay, so therefore, these fetuses are getting a lot of glucose, a lot of fat, right? A lot more, too much of everything. All right, so they become hyperglycemic, hyper, going up too much. The fetal pancreas produces then a large amount of fetal insulin. Has to, remember? Okay. Which then leads to an increase in their insulin level. Okay. Along with excessive production of protein and fatty acids. So therefore, with all this, you got too much insulin production, you got too much protein, too much fatty acids, too much sugar. It all ends up with what we call an LGA baby, large for gestational age newborn. And these newborns weigh like 9 pounds or more. And these are called macrosomic babies. Macrosomic babies. Okay. The large babies. And in your book, you had a really good picture of a large baby. And they have big, big heads. Big heads. And hopefully these big babies can be born C-section. But, you get to have these moms and they want to have these babies. And so then we try vaginally. And then we can have shoulder dystocia where the shoulders are too wide and they have to break the clavicle. And so that happens. Now, what happens after birth? Okay, so we talked about what happens what happens afterwards. Well, after delivery, they can have low blood glucose levels, right? And what we call a cushingoid appearance. That big old face with the big cheeks and little slits for eyes. And people they love to see big babies. They think big babies, healthy babies. Ooh. Okay, but these babies are really sick babies. Their biggest problem after the cord is cut can be hypoglycemia. Now their low blood sugar goes down quick after delivery. Low blood sugar can lead to low calcium levels, hypocalcemia. And then another complication, which is never good, is hyperbilirubinemia. Hyperbilirubinemia, too much bilirubin is being circulating, which can cause what? Kernicterus. You can see how these complications can occur. So you want to nip that in the butt, the hypoglycemia. You want to get that very quickly. These babies are sick. These babies usually are in the NICU. They have an IV in them. We're monitoring their heart. They have a pulse oximeter on them and making sure that they get enough oxygen. And then we have to monitor their glucose ever so much. Okay. Because remember something. When a glucose levels drop below 40 milligrams per deciliter, it can rapidly and permanently cause brain damage. So glucose levels below 40 milligrams per deciliter can result in rapid and permanent brain damage. Not good. So we're going to monitor the glucose levels, like I said. We're going to monitor their vital signs. These babies can be irritable because they're looking for their sugar, okay? And they have tremors. And, excuse me, they can have respiratory distress. So they'll be kept warm so they don't get cold stress. We're going to have an IV, like I said, monitor the glucose levels, vital signs, and watch for tremors. And then, of course, making sure that they're able to oxygenate, they don't go into respiratory distress. These babies are sick babies. Okay. Well, guys, congratulations. You made it all the way through. I went over every concept from chapter 10, 12, 13, 14. Ask yourself, about the key terms in front of every chapter. If you're not sure of those key terms, be sure tonight, be sure to look at them. Okay. It's always good to know the normal signs of a newborn. Let me see. We went over everything. Okay. Just checking here. If I was to ask you what's the color of stool for a breastfed baby, what would your answer be? Remember, it's that yellowish, grainy kind of looking stool. If you don't know that, go into the chapter on the term newborn. Okay. All right. Let's see. We went over postpartum hemorrhage. We went over hypovolemic shock. Uterine atony. We went over phototherapy. We went over cleft lip, cleft palate, hydrocephalus. We went over the normal oxygen reading for a preterm baby, and that was 92%. We went over the different colors of the stool. Okay, we did that. We went over hip dysplasia. Woo, we did a lot. Okay. We went over infections and complications, like chapter 10 was on that. So if you're not sure of all the infections and what to look for, make sure you go over that. Make sure you look at methogen and what is methogen, what's it used for, what's oxytocin, what's it used for, what are the signs for deep vein thrombosis. Okay, how to prevent. How do we prevent a DVT from happening? Early ambulation. All righty. We went over mastitis, uterine atony. Okay, what promotes the flow of milk? Remember, nice warm shower flowing makes that milk release. Remember, 2 hormones needed for breastfeeding would be prolactin and oxytocin. All right. We went over survival reflexes of the newborn, but if you don't know them, then look them up. Okay, go into my PowerPoints. They're there. Okay, let's see what else. We went over PKU, Down syndrome, glycosemia, diabetes, neonatal absence syndrome, okay, erythroblastosis fetalis, ROGAM, meconium aspiration syndrome, macrosomia. Whew, I'm getting tired just reading all this. Okay, we went over spina bifida. Okay, bulging fontanelles on a newborn is a sign of what? Remember, increased pressure, cerebral spinal fluid, okay, especially in the hydrocephalus, they're going to have bulging fontanelles. There's too much fluid up there. If a fontanelle is sunken, which is low, right? Sunken, that means they're dehydrated. Good. Okay. Oh, a post-term baby is 42 weaker. Okay. We talked about surfactant quite a bit on this review. So if you don't know about surfactant, listen to this review later. All right. Okay. And then go over circumcision. That would be on the term newborn. All right. If you're good on all that and you can answer all that, then you're in good shape. Be sure that you download the exam prior to taking the exam. It really works much better. You can start downloading at 2 p.m. Eastern Standard Time. That's when it's able to download. Be sure to listen to the code when I give the code out. I put the code in chat, but just give me a few minutes to type it in. It's a long code, and just make sure you have your ID. You have one piece of paper with no writing on it, and your area is clear of anything. Okay, well, I hope you've taken the time to review this PowerPoint, and I hope you do well. And I'll see you tomorrow. Okay, I wish everybody the best. Remember, guys, you got this. Okay, there's no need for any kind of test anxiety because you're prepared. You studied, you read, you attended a review, you're listening, and you're prepared. When you're prepared like that, it's nothing. Now, do me a favor. There's no award for a student getting done early. Okay. You have an hour and 15 minutes to do this exam. Okay. So read these questions. That's the problem. The problem is sometimes you're not reading them like you should. Okay. All right. I'm going to say goodbye now. Bye bye, everybody. Bye.